All right, well, I think we can go ahead and get started. It's great to welcome everybody to this Cancer Therapeutics program meeting and to welcome Benny, who's the co-leader of this program. I almost wish that we had Zoom conferences last year because they're clearly popular, especially with colleagues all across the campus and in the different hospitals. These program meetings have been relatively informal in terms of audience participation during the talks, and really the idea is for the audience to learn about the work of the speaker, but also to encourage discussion at different points with the idea of thinking about new collaborations or new grant submissions that would be collaborative. So, Benny, really, you don't really need any introduction here. You're the co-leader of the program, and we look forward to your talk today about new therapeutic targets and treatment strategies in castrate-resistant prostate cancer.
Okay. Well, thank you, Wafik, and thank you everyone for attending the meeting. We're going to discuss essentially, essentially three areas. I'll give an overview of the clinical states and treatment of metastatic prostate cancer. Then we'll discuss some emerging subtypes, molecular defined subtypes of prostate cancer that are clinically relevant and are changing our treatment paradigm in the clinic. And then I'll spend a few minutes talking about some ongoing projects that we are working in collaboration with Wafik in developing some novel combinations in prostate cancer targeting the mitochondria. So the treatment of prostate cancer, metastatic prostate cancer, has evolved significantly when we look back at the initial pivotal discovery that surgical castration of men with metastatic disease led to significant tumor response by Dr. Huggins back in 1941. And those results were not only important, that reflected by the fact that it led to a Nobel Prize, but also it really focused the treatment of prostate cancer in the androgen signaling pathway. And really that became the main pathway that it was studied for this disease for several years. And to this date, it's basically one of the pivotal treatment modalities for metastatic prostate cancer. So from that discovery, several strategies to induce castration and reduce the levels of testosterone have been developed, including LHRH agonists and inhibitors, as well as androgen biosynthesis inhibitors like abiraterone that inhibits the production of testosterone in the adrenal glands, and also a number of androgen receptor inhibitors that have been developed and incorporated in the clinic for many years, as well as more recent, as I mentioned, CYP17 inhibitors that inhibit the production of testosterone. So this has really driven the treatment of prostate cancer for all these years. And along with that came the recognition that the cancer cells, they develop escape mechanisms that even in the setting of low levels of testosterone, they can find ways to keep the androgen signaling pathway active, either by production of in the microenvironment of testosterone or crosstalk between growth factor receptors, amplification of androgen receptor, as well as alteration in repressors and regulators of the expression of these receptors. So all this occupied the researchers for all these years trying to understand the androgen signaling, which in one way it was extremely beneficial because, of course, we learn a lot about the pathogens of prostate cancer, but on the other way, you can also imagine that it created this bubble around prostate cancer and androgen signaling and distancing the attention to other important pathways. Just to give an idea, for 75 years, the treatment of newly diagnosed metastatic prostate cancer remained androgen deprivation therapy. And the reason for that, of course, is a very effective strategy that 90% of patients respond to that. On the other hand, the duration of benefit used to be only about 18 months. So ultimately, all the tumors would develop castration-resistant that usually would take 1.5 years to 2, that could lead ultimately to a lethal metastatic prostate cancer. So until around 2015, all the treatments for metastatic disease were directed towards this subtype that we call castration-resistant prostate cancer, which is basically the tumor that continues to grow despite low levels of testosterone. So all these drugs that you see listed here were developed in that setting that usually represented patients, in advanced stage with multiple comorbidities and advanced disease with all the challenge that that brings. So it was in 2015 when this clinical trial was finally reported. It took several years to complete, but basically it was a very simple question that was trying to answer was whether there was a benefit of adding chemotherapy to the upfront treatment of metastatic prostate cancer, which in that setting would call the castration-sensitive disease or hormone-sensitive disease. And ultimately what this showed was that there was a clear benefit for those patients with a overall survival benefit of 10 months across the board. However, interesting enough, that benefit was more pronounced among the patients with high volume disease, which essentially were patients with visceral disease or multiple bone mets, at least 4 bone mets. And that benefit was not seen among patients with low volume disease, which, that it was a major breakthrough in terms of improvement of outcomes, but it's still the patients were not curing this patient, were delaying the development of castration resistant. But was a significant advancement that brought the attention to this entity of metastatic castration sensitive disease. All the work was being done with castration resistant, and now with these results, just redirected the whole field of advanced prostate cancer. And it took 75 years for this, and then after that, after 2015, things have been evolving more rapidly with, subsequent studies showing that there is a benefit of adding other agents to the frontline treatment, including abiraterone and enzalutamide. So, and that continues to evolve. But it's important to see that now the paradigm of treatment is changing. We're seeing more options for patients in the upfront setting that helps to eliminate those clones that ultimately would become resistant. And then, of course, new drugs continue to be developed in the castration-resistant setting with the goal to move to the upfront setting. And during this time, in early 2014, 15, we learned a lot about the molecular aspects of prostate cancer, including the TCGA results that this analysis was basically was mostly done in primary tumors, which is an important aspect. But essentially, we see important subgroups of disease. 4 of them are related to the fusions involving the ETS family of transcription factors. There is also other 3 subsets, relatively small, 11% with SPOP mutation, another 3% with FOXA1, and then IDH1, only 1%. Interesting though, is that about 25, a quarter of those cases, they could not fit in any of those categories. So there's still a quarter of the patient that we could really not characterize well. And when you look at the genomic landscape of metastatic disease, you see these frequent alterations. The first of them, alterations in androgen receptor up to 62% of tumors, alteration in P53, very frequent as well, and PI3 kinase pathway. And you see also in DNA repair, about 22, in some studies go up to 27% alteration, which will be very relevant as we discuss this topic. So just to give an idea, just recently, literally last week, a study was published showing, the first indications of the genomic findings of metastatic castration-sensitive disease. This was a study from MSK that basically sequenced about 450 patients, tried to understand what's the genomic finding that leads to these clinical features of low volume disease and high volume disease. To this date, we treat, when we see a new patient in the clinic with metastatic disease, we still treat them based on the clinical features of volume of metastatic disease. But what does that mean molecularly? Well, this study seems to suggest that tumors with high volume disease, they have more frequent alteration in Notch pathways, cell cycle, epigenetics, and DNA repair. And interesting enough, androgen receptor is way down here without many alterations. However, when you look at the impact of these alterations on the time to development of castration resistance, or even overall survival on the right, you see that androgen receptor alteration has a significant impact on that, with increasing the velocity to development of castration resistant, but also associated with worse outcome. The important genes here in pathways include cell cycle, MYC, P53 that we knew about. Notch was relatively new. And you can see as well an impact of DNA repair that we'll discuss more. The impact of DNA repair mutation was more profound when look at only BRCA2. And interesting enough, when signaling seems to have a favorable impact on the castration-sensitive disease, as well as mutations in SPOP. So this shows us that the field, it's still evolving on the understanding of the molecular feature of metastatic castration-sensitive disease. Another interesting finding that was described by the group at WashU recently, about 2 years ago, almost 3 years now, is that there is a subgroup of prostate cancer that do not express androgen receptors and also do not have any features of neuroendocrine tumors. And they call these tumors the double negative prostate cancer. And interesting, the frequency of this tumor seems to have increased between the period of 1998 to 2011 and to the period of 2012 to 2016, which is when we introduced in the practice androgen receptor inhibitors such as enzalutamide and abiraterone, which are called the second generation androgen inhibitors. So the proportion, at least according to this study of necropsy autopsies, the proportion of those double negative tumors went from 5 to 21%. The reason that I bring this up is this offer the possibility that some tumors, in fact, you might not need to treat with androgen deprivation therapy. That really raised the question whether we need that for every single patient. As you can imagine, that strategy of treatment brings a number of side effects and long-term toxicities that can be challenging for many patients. And to this date, when we diagnose a patient with metastatic disease, they pretty much stay, with androgen deprivation for the rest of their lives. So this finding really asks us, not only at diagnosis, but during evolution, can we identify tumors that can be not responsive to androgen, and maybe we can tailor the treatment to avoid androgen deprivation therapy in those patients. These are some of the, the genomic alterations that they saw in those subgroups of tumors, and nothing extremely remarkable in terms of the frequency. Maybe a little bit higher numbers of BRCA2 mutations among those, but nothing dramatic. But they clearly have a distinct phenotype of gene expression. So what I'll do next, I'll just go through these 4 groups of more clinical relevant subtypes of prostate cancer that are emerging more recently in the past few years. The first one that we'll discuss is essentially the BRCA2 mutated metastatic prostate cancer. And this story actually started early 2000 when 2 papers were published at Nature that essentially showed that the selectivity and sensitivity of cells deficient in BRCA1 or 2 to PARP inhibitors. So PARP inhibitors at that time were being developed as drugs for actually potentially as radiosensitizers. But these early results showing that the cells carrying BRCA1 or 2 deficiency, either heterozygous or homozygous, they were extremely sensitive to PARP inhibitors, really opened and created a whole new field. This is the other paper that was published by another separate group that's showing the same, pretty much the same sensitivity. And basically what this did was it really created this concept of synthetic lethality as a treatment strategy for tumors carrying BRCA mutations. So the idea was that if you have a cell that has a BRCA2 mutation or a deficiency in the homologous recombination, that cell would rely on base excision repair to repair the DNA. And that it's of course dependent on PARP1. So, and then if you block PARP inhibitor, use PARP inhibitor in those cells, they would, they would die because you basically would be blocking those 2 critical pathways. So this was the new concept that basically that we could treat cancer with using a single DNA repair inhibitor without chemotherapy. So that concept was explored extensively early on, but with the focus in tumors with BRCA mutations. And this is a phase 1 trial that was published in 2009 that was exploring that question. And essentially they saw, as you can imagine, multiple responses in breast and ovarian cancer that really focused and brought the attention for the development of this drug in those histologies. However, in that paper, there was a description of this case of prostate cancer showing this remarkable response of PSA lasting greater than 2 years and with resolution almost of some of the bone metastasis. And this, it really caught the attention of a lot of people, but given that only 3 to 5% of patients with prostate cancer have germline mutation, that in a different way, it didn't brought a lot of traction in the field for this small subgroup of patients. And the change in that perspective changed dramatically in 2015 when actually an investigator-initiated trial, this one that was done in UK, but some of the same group of that initial trial, they essentially what they saw was that in prostate cancer, not only mutations in BRCA2, but mutations in other genes involved with homologous recombination could represent, could lead to sensitivity of those tumors to PARP inhibitors. So this was a relatively small trial that included basically 49 patients with refractory, heavily pretreated prostate cancer. And they basically sequenced those tumors and saw that 16 out of the 49 had mutations in one of those genes involved with homologous recombination. That included not only BRCA2, ATM, CHEK2, PALB2, and so on. And in remarkable results showing that basically 14 out of those 16 patients had response to olaparib. So these results really changed the field and opened, another perspective of looking at not only BRCA2 mutations, but especially looking also at somatic mutations. So this was the other, component of the story that we used to pay attention only to germline mutation, but in fact, somatic loss of BRCA2 could lead to significant response to PARP inhibitors. And this ultimately led to large phase 3 trials with olaparib in patients with metastatic prostate cancer, like this one, the PROfound study that was published recently. In this study, they basically, patients with metastatic prostate cancer were randomized to 2 cohorts. One cohort with patients that had only BRCA1, 2, or ATM mutations, and the other cohort, patients with all the other alterations. Basically, looking at the numbers of mutations that had response in that previous study gave the support to focus on only those 3 alterations. And patients were randomized to receive olaparib or other standard of care options. And this study essentially showed a remarkable response and improvement of progression-free survival for olaparib when looking at the cohort A with BRCA1, 2, or ATM mutation, basically more than doubling the median progression-free survival, which we quite didn't see the same impact when we combined both cohorts, which highlights the importance of those alterations. There was also some trend of improved survival in those patients. Look at cohort A with the BRCA1, 2, and ATM, you see an improvement from 15 to 18 months. And again, when you combine both cohorts, the benefit gets diluted with the other alterations. And interesting, what we see here was that when we looked at this data and look more carefully doing an exploratory analysis according to specific mutations, you see that clearly the benefit was more pronounced in BRCA2. And other genes were also relevant, like CDK12, it showed some benefit, but it was not statistically significant. ATM was a surprise. We didn't see a significant impact of ATM mutation on this trial. BRCA1 also was not as remarkable. And others are clearly relevant, like RAD51B, and as well as PALB2 that's not displayed here. But essentially, what this tells us is that not all DNA repair mutations are the same, and they do not inform the treatment response in the same way, which is the approach that basically the ovarian and breast cancer has taken in focusing more in BRCA2 and 1 mutations. And another trial also investigated almost the same question using a different PARP inhibitor in a patient population. It's slightly different, but that included patients who had received chemotherapy before, but essentially it came to the same conclusion, that showing the high response rates in the range of 43% on this trial. The other one was around 33% among patients with BRCA1 or BRCA2 mutation. And essentially those trials led to the approval of those 2 drugs, rucaparib and olaparib, for treatment of metastatic prostate cancer with BRCA2 mutation. And that also is driving our decision to perform genome testing in every patient with metastatic disease currently.
So Benny,
decide how to fit those treatment options. And as this data evolved, also evolved our knowledge about the importance of BRCA2 mutation in prostate cancer, which is emerging as its own entity. These patients, we know that patients with germline mutation in BRCA2 have prostate cancer at a younger age. They have more aggressive disease with higher risk of distant metastases and decreased survival. They have, even at the castration-sensitive setting, molecularly, they look more like castration-resistant prostate cancer with higher frequency, for instance, of MYC amplification and other features that give these tumors their more aggressive pathological behavior, such as genome instability, and also the association with intraductal carcinoma.
So Benny.
And it's interesting when you look at the BRCA2 mutated prostate cancer, as you can see, not all of them are also the same. So and so that you clearly see that patients, a wide range of duration of response among those patients with this BRCA2 mutation, which suggests that not all the mutations respond the same way to the PARP inhibitors, and whether they are missensed or by allelic loss. So I think this is an area that we're still understanding better. In ovarian cancer, for instance, where there's data more mature, it suggests that homozygous deletion are associated with longer duration of response. In prostate cancer, the data is still evolving, but also it's important to realize that, this is the response graphics from the recovery study, that there are clearly a group of patients that even in the presence of these mutations, they do not respond. Either patients with biallelic loss or not, but so there are still patients with primary refractory disease despite having BRCA2 mutations. And maybe some of that heterogeneity of response, some suggest that has to do also with the ability of the tumors to develop reversal mutations, which is basically the tumor that has a mutation in BRCA2 can develop another mutation that restore the protein. This is a case that we treated a patient with metastatic prostate cancer that had a germline mutation. And then later he developed this second hit, which was this somatic mutation. And he had a dramatic response to olaparib and remained on that treatment for about a year with response in the liver disease and lymph nodes. But later, 1 year later, he developed progression of the disease on the bone. And when we did a CT DNA analysis, it showed that he had developed all these multiple reversion mutations that not only restore the second hit, but also restore the germline mutant allele. So that tells how complex this is in the evolution of the disease, which might explain that maybe the duration of response will depend on which mutations the patient carry and whether that mutation is more susceptible to development of reversion mutations. When we look at a larger retrospective analysis, we saw that approximately 40% of patients that had BRCA2 germline mutations detected by ctDNA show reversion mutations. So I don't think it's that rare. Now that we're going to be using these drugs more in a larger number of patients, we likely will see this more often. And it creates this avenue to explore this by using ctDNA as during the assessment of response of those patients, which is an interesting way to monitor. So in summary, I think what we can say at this point is that mutations in some genes are not as associated with higher response rates. For instance, ATM, CDK12, and CHEK2 have a lower rate of response compared to other mutations. In one of the trials, the Triton-2, which is the recovery trial, only 10% of the patients with ATM had response to PARP inhibitors. And what it's been explored now is maybe those patients with ATM mutations, those tumors tend to rely more on ATR, and there is a growing interest in the ongoing trials looking at ATR inhibitors in tumors with ATM mutations, sort of a diversion from using PARP inhibitors in those subgroup of patients. The CDK12, we'll talk more in a little bit, but it's becoming more relevant actually for response to immunotherapy than to PARP inhibitors. And going beyond, the DNA repair defect, there are a number of strategies being explored in combination with PARP inhibitors, or given the impact of these drugs, including, for instance, there is some data suggestion that when you block PARP, you can increase the expression of PD-L1 and also the new antigen burden. So there are trials looking at combination of PARP inhibitors with checkpoint inhibitors. Also, as I mentioned, trials looking at combinations of PARP with ATR inhibitors and other inhibitors of WEE1, for instance, that regulate DNA repair as well. And interesting enough, we'll talk is that the combinations included with PARP inhibitors with PI3 kinase, which is relevant for this pathway. There has been a number of studies, more preclinical studies, especially that from models of prostate, breast, and ovarian cancer, showing that a clear synergism between PARP inhibitors and PI3 kinase pathway inhibitors. And that has to do with both, the inhibition of PI3 kinase compromising homologous recombination, but also impacting even the expression of the BRCA1 gene. Earlier studies looking at this question included a olaparib plus buparlisib, a PAN PI3 kinase inhibitor that showed response rates about 30% of the patient, but there was a high rate of toxicity. More recently, another PI3 kinase alpha inhibitor showed response up to 36% in patients with ovarian cancer, and interestingly enough, even in patients without mutations in DNA repair genes. So this gave us the preclinical data and support to propose this clinical trial that's ongoing right now, which investigator-initiated trial looking at the combination of copalisib, which is a PI3 kinase inhibitor, with rucaparib, a PARP inhibitor in patients with metastatic castration-resistant prostate cancer. The study is a phase 1/phase 2. At the phase 1 component, we're doing a dose escalation. And in this setting, we're not selecting patients based on the presence of DNA repair mutation, which in itself will be an interesting analysis to see if we find any response among patients without DNA repair. But it's basically at this earlier phase, we're looking at safety and trying to find the dose to be exploring the phase 2 component, which will be an expansion cohort focusing tumors with DNA repair mutations. We have 3 patients in treatment right now, and we're looking forward to open the second cohort relatively soon. And this trial, we are actually opening at UCSF in collaboration with Rahul Ardwal. And interesting, just so that it's sort of a validation of that approach, this trial was just published 2 weeks ago, looking at olaparib with an AKT inhibitor in patients with BRCA1 and 2 wild type and mutant tumors. And interesting, what you can see here is that, of course, we see a number of response across multiple tumor types, especially if they had germline mutations or somatic, and including patients who had previous PARP inhibitors. So, which raises the question whether this combination could potentially overcome resistance to PARP inhibitors. And this is to give an example of the point that I made earlier about the possibility that this combination might be relevant even for tumors without mutations in these pathways. In red, you see responses in tumors that had alterations in both BRCA and PI3 kinase. In blue, you see the response in tumors who had only DNA repair mutations. Here, tumors in green that had mutations only in the PI3 kinase. And then you see a few response in tumors that had none of those alterations, which is interesting, including some in prostate cancer. So that's a ongoing avenue of a number of trials exploring how can we not only overcome the resistance to PARP inhibitors, but also how can we make those responses more durable. I think we're going to see more also, trying to explore the impact of reversion mutations in those responses. And briefly, immunotherapy in prostate cancer has been a challenge, as you all have heard. Despite having Sipuleucel T, which was a vaccine developed for prostate cancer and approved, that we still have not seen a remarkable impact of checkpoint inhibitors in prostate cancer. But there are 2 subsets of disease that it can potentially be very helpful. One is this: about 3% of prostate cancer can have microsatellite instability. In those patients, they can potentially have durable response to checkpoint inhibitors. This is one of the largest cohort today that confirm that approximately 3% of patients have MSI high, and the response, as you know, it's about 54%, which is in agreement with the other results we've seen with MSI high tumors of other histologies, including colon cancer and others. So it's within the same ballpark. Some of the remarkable aspects is that some of this response can be quite durable. The other challenge that we continue to see in prostate cancer, when discussing the use of checkpoint inhibitors, is what's the value of PD-L1 expression. This is maybe the largest study that look at pembrolizumab in metastatic prostate cancer, that essentially what they saw was this overall response rate of only 5% in PD-L1 positive and only 3% in PD-L1 negative. However, those are small response rates only for measurable disease. A lot of the patients have non-measurable disease with bone and PSA only, that those response rates might go higher to 15%. But the important point is that some of those responses, again, can be durable. So it's a relevant finding, not as dramatic as in other histologies, but certainly in prostate cancer, it's worthwhile exploring more. A very interesting result came, looking at this CDK12 loss in prostate cancer. And what's has been shown is that tumors with CDK12 loss, they have a very high burden of new antigens and an increased T-cell infiltration. And those tumors that were originally thought to be responsive to PARP inhibitors, in fact, they seem to respond better to PD-1 inhibitors. This was a small retrospective cohort that was presented recently, looking at those subset of patients. And again, you see maybe it's a very small number, but maybe we might be seeing a high response rate among those patients. There's still some response to PARP inhibitors, but that response has been very heterogeneous across the studies. So in the last few minutes, I'm just going to spend some time talking about two interesting approach that we're trying to explore in collaboration with WAFIC and other colleagues here at Brown. One is looking at the role of BCL2 proteins in the modulation of this progression from castration-sensitive disease to castration resistance, but also look at the role of these BCL2 proteins in the development of metastasis. And the other project is trying to look at the mitochondria as a target in prostate cancer, using ONC201 as an activating tool of this protease called CLPP. So the CLPP, it's a very interesting protease that I'm just starting to learn more about it, but it's essentially, you can think of this as the similar counterpart of the proteasome that we have in the cytoplasm. Essentially, this protein it forms this complex with another CLPX, and essentially helps degrade misfold proteins in the mitochondria and control the metabolism. What is interesting, there has been a number of studies, mostly interesting in infectious disease, looking at compounds that could inhibit this protease. And some of those have actually been developed as antibiotics for treatment of refractory bacteria infections. And there is a program that was looking at this protease for treatment of cancer, and including leukemias and lymphomas, and saw that the activation of this CLIP could lead to cell death, and it was involved disruption of the mitochondrial respiration and oxidative processes. And interesting enough, during that screening of when they were looking for compounds that were interacting with this protease, they found that ONC201 and ONC212 came up in the pre-screening as activators of this protease. And essentially what they do is, you really, it's almost like a trash can that suddenly now they expand the opening, and not only misfolded proteins go through this, but also now, normal proteins in the mitochondria get degraded as well. So this has led to a significant interest in the increased use of ONC201 and 202 as basically activators and to disrupt the mitochondria. Interesting, these results were published a few years ago, and they look at the expression of CLIP-B among different tumor types. And if you look here in prostate, this protease it's increased, the expression is increased in the tumor samples as opposed to normal tissue. And this actually is seen across other tumor types, including breast and uterine cancer, and in other tumor types seems to go the other way around, including in HCC. But basically this suggests that in prostate, there might be, there's a clear overexpression of this protease in tumor cells that creates a possible biomarker for the ONC201 as an activator. And it seems that the expression of this protease is associated with outcomes in some of the malignancies. So that this became even more interesting when we look back at the data that has been published showing that single agent ONC201 has in vivo activity in models of prostate cancer. And even more striking when we looked at some of the data from the early phase 1 trial that saw some response among patients with prostate cancer. For instance, some of those patients with enzalutamide-resistant prostate cancer had prolonged PFS of greater than 30 weeks. And you can see here on the right some of the measurable disease presenting in response to ONC201. And this was in part driven also by the immunostimulatory activity of ONC201 in those specimens that, as demonstrated here on these serial biopsies of the same patient that had the response. Basically, you see an increased infiltration of NK cells in the lymph node biopsy of the patient that responded to ONC201. So this led us to explore in the lab with Wafik the potential role of combining ONC201 with a new androgen receptor inhibitor called darolutamide, which has been recently approved for treatment of metastatic disease, and has the unique aspect that it seems to be active against prostate cancers that carry mutations that are making the tumors resistant to enzalutamide and other AR agents. And there's some possible increased efficacy of this compared to other AR inhibitors. But essentially what we see here is a significant synergism between those two drugs, especially in two cell lines, 22RV1 that has ARV7, which is a variant of AR that brings resistance to enzalutamide, and also a clear synergism in CAP, which is has a wild type AR receptor. Those are the two cell lines we don't see as a strong synergism, and those are cell lines that are associated with more neuroendocrine features. We also saw that this combination led to significant apoptosis in those cell lines, and interesting, they also inhibit the nuclear translocation of AR in both 22RV1 and CAP. So it seems that the ONC201 was able to potentiate this inhibition of AR translocation to the nucleus. So we are in the process of having discussions right now to explore a potential investigator-initiated trial looking at this combination for metastatic castration-resistant prostate cancer. And I'm just going to finish with this other project that it also relates to cell death in mitochondria, linked to prostate cancer, which is being driven by mostly by Luke and Praveen, to fantastic medical students, and also in collaboration with Rachel Somedi from the Brown Center for Bioinformatics. And basically the background for this is that we've known that BCL2 has been involved with resistance to treatment in prostate cancer, not only to androgen receptor inhibitors such as enzalutamide, but also to chemotherapy. For instance, inhibition of BCL2 can increase the sensitivity of prostate cancer to those Taxol. What we don't know is what's the role of the other members in this family that regulate the intrinsic pathway of apoptosis. And that's particularly relevant considering the number of agents currently in the clinic that are being in clinical trials that target several of those members, including BCL2, BCLXL, MCL1, and even components of the extrinsic pathway. So we believe that looking at the differential expression of these genes between tumor and metastatic sites, it can lead to important insights into novel strategies to target the cell death pathway in apoptosis in prostate cancer. So essentially what we'll be doing, actually already doing, is looking at RNA-seq data from patients with metastatic disease, both from primary tumor and metastatic sites, and looking at expression and try to identify correlations between outcomes in those patients. So in conclusion, I think we could see that there has been significant progress in the treatment of castration-sensitive disease and resistant prostate cancer. And I think we're starting to break that shield of focusing only in androgen signaling pathway and starting to explore other pathways that are just maybe even more relevant in subsets of disease. We're clearly starting to have a more well-defined molecular subgroups of prostate cancer. So not everyone is treated equally with ADT alone. So we're starting to have clearly emerging this entity of BRCA2 mutated prostate cancer, and also some other subtypes such as those with MSI high and CDK12. And I think what we'll see in the next few years is a number of novel strategies looking at ways to optimize the efficacy of PARP inhibitors, whether by selecting according to alterations in DNA repair, or looking at combinations that could enhance their efficacy. And we're looking forward to continue exploring this pathway of the targeting the mitochondria with ONC201 and other derivatives in prostate cancer. And I'd like to thank everyone in the division, our colleagues, and the team at the LOCR, as well as everyone at Wafik's lab for the collaboration, and Praveen, who's and Luke, who are doing the work in BCL2 family members, and Rachel Somedi for helping with the bioinformatics analysis. Thank you, everyone.
Thank you, Benny. Can you hear me? Benny?
Hey, Benny, it's Howard. Can you hear any of us?
I think, can you hear me?
Yes, Benny, that we're having trouble talking with you. That was a phenomenal talk, Benny. There's so many exciting possibilities that you gave, and I thought the work on the PI3 kinase and then with the PARP inhibitors is special and very exciting. I know Wafik had a question. I'm not sure if he can get through.
Well, I don't know if Benny can hear us.
Now I can hear you.
Okay, all right, great. So that was a great talk and covered a lot of ground and some really exciting progress. One question I had early on, it was interesting how BRCA1, BRCA2 mutations, had some unexpected results with the with olaparib and with PARP inhibition, which we have heard about this tissue specificity with certainly with the BRCA1 gene, but my question is whether there are any biomarkers with these BRCA deficient tumors that would predict whether patients respond. And I guess the same would be true with other DNA repair defects. Sometimes they respond, sometimes they don't, sometimes it's a low percentage. So any thoughts on that?
Yeah, I think, and I'm sorry, I just realized now that I was not hearing what everyone was saying. I was trying to ask questions. Anyway, so it's not clear yet what, which mutations are, drives more sensitivity versus others. The data, there is some data in ovarian cancer showing that there's this group of mutations that are associated with prolonged response versus this other group of mutations that are associated with shorter response, and maybe those mutations are more susceptible to the development of reversions. But also the point of having the biallelic loss seems to be very important. So it's still not clear. And when we get a patient today with that you do the sequencing, if it's it's a variant of unknown significance, sometimes we don't know if it can respond. One of the most remarkable response I've seen thus far with olaparib was with a patient with PALB2 that actually was listed as a variant of unknown significance. It was a remarkable response with liver disease and lung, but lasted only 4 months.
Is there a difference between a germline versus a somatic BRCA mutation in response?
No, that's a very good point. So in the Triton 2, they look at that data and the response were the same.
With the BRCA deficiency, so you're more at risk of having double-strand breaks, and one of the biomarkers for double-strand breaks is gamma H2AX, the phosphorylated histone 2 AX, and I'm wondering if anybody has looked at that at baseline versus response. The more deficient the pathway is, the more double-strand breaks are going to be even at baseline before any sort of therapy.
Can you hear me, group? Andre here.
Yeah.
Yes.
So it's interesting to remember that the Ariel trial in ovarian cancer with rucaparib in ovarian cancer included the patients with loss of heterogosity. And of course, the definition of loss of heterogosity varies from foundation to caries. And this is an important point that caries is bringing loss of heterogosity to 250,000 locus in the DNA now. And that was proven to be a differential response compared to just BRCA. So I just wonder if for other BRCA mutated tumors, we can try to test the response in loss of heterogosity. We don't know if H2 gamma, I think it's H2 gamma AX, correct me if I'm wrong, Wafik, if it's just the histone or if it's the whole concept, what genes are actually being affected by?
Yeah, so histone H2AX binds to double-strand breaks, and it gets phosphorylated when you have double-strand breaks. So it was a biomarker developed at the NCI years ago. And, so if you break DNA or anything that causes DNA damage will make it go up. And it seems like a good biomarker that would predict response in the case of deficiency in homologous recombination.
So I think the point I think that you're touching also is, we still don't have a functional assay to give us an idea of homologous recombination functionality. So we still rely on the mutations, but the functional impact, we don't have a way to measure. The gamma H2AX was, as you said, it was used as a pharmacodynamic biomarker in the initial studies, but has never been incorporated in the clinic as an assessment of response. The ctDNA analysis to monitor for the development of reversion mutations seems to be, an interesting aspect, but again, it doesn't tell us about sensitivity of the disease.
What do you think of, if I may ask Benny or Fik, what do you think, knowing that loss of heterogamy as a predictor of homologous repair deficiency for ovarian cancer was done through myriad genetics, a very specific test. What do you think about taking this concept to other homologous repair deficient tumors, pancreatic, prostate, and, you know?
So I think what the data it's suggesting also that we might be, you know, this concept of DNA repair mutation might not prove to be, you know, very helpful clinically. At least in prostate cancer, what we're seeing is that in fact, you know, some mutations are more relevant than others, and it might not be maybe the best approach to focusing any mutation of DNA repair. So
yeah, I mean, my comment, Andre, is what that gets at, it's some sort of a marker of genomic instability, you know, lots of loss of heterozygosity throughout the genome. And it kind of brings up another approach that has been used in the past by some investigators interested in PARP inhibitors, and that involves combination with DNA damaging agents. And as far as I can tell, I don't think that bore fruit, and I don't know if, you know, the extent to which that has been done in prostate cancer with DNA damaging chemotherapy combined with PARP inhibitors.
So,
Benny, why would you postulate in this model of cancers with DNA repair defects that there seems to be a dramatically different prognosis, especially when we're dealing with primary prostate cancers in patients with BRCA2 mutations as opposed to BRCA1 mutations? And do you know of other malignancies in which there could be a difference in prognosis based on which one of the BRCA mutations are present?
yeah, in prostate cancer, the mechanisms I cannot explain fully why. BRCA1 is extremely rare in prostate cancer, but it seems that the impact on the repair, on the DNA repair mechanism, and it seems to be greater with BRCA2. I've seen some reference to the impact in the, you know, when there's the replication fork, it's progressing, and if you don't, the BRCA2 loss has a greater impact in causing additional, you know, DNA damage, but not allowing the progression of that replication fork. So I think they are not, you know, even PALB2, which is interesting, some even call it, you know, BRCA3, seems to have a greater impact than BRCA1. So I think it comes down to the function of those proteins in the DNA repair machinery that are very distinct. They just are called breast cancer genes by, you know, how they were discovered in a sense, but I think they have unique functions.
One comment I'll make is that there's a data set from Memorial Sloan Kettering that has suggested that when the mutations occur in some tumors where the gene is not a driver, the impact of the therapy on outcome isn't seen. And, you know, it's not really well understood, but I guess the best way to explain it is, you know, there is some tissue specificity, but when these genes are mutated, in some situations, they may not be the drivers. And so that, you know, that's one explanation that has emerged, but I don't think it's well understood.
Benny, this is Bill. Just, I can make a quick comment about the BRCA mutations in breast cancer. In patients who have BRCA1 mutations, the vast majority of those cancers are triple negative. And it's interesting, when they've looked at the BRCA genes in those cancer cells, in many cases, the functional copy of BRCA1 has been lost. So those heterozygous cells have actually become homozygous, you know, for BRCA deficiency. The same thing is really not seen. So the distribution of cancers in BRCA2 is more similar to the distribution of cancers in non-BRCA carriers in terms of hormone receptor status and HER2 status. And there is not that profound loss of that functioning BRCA mutation in those cancers.
That's very interesting. So,
Guys, I hate to interrupt. I think we have Nimesh's Zoom call right now.
Yeah, I think we're coming to the end here. I don't know if there are any other burning questions, but thank you very much, Benny. And would just like to remind everybody, Bob Weinberg is speaking tomorrow, and I think the link has gone out. So we look forward to his talk. Thank you, everybody.
Thank you.
thank you.